How do we treat diabetic eye disease? Well, diabetic eye disease can be present but go unnoticed, and early treatment before visual loss occurs gives you the best chance of maintaining a good level of vision. This is why it is so important to have a screening check of the retina every year even if you're not noticing any problems if you're diabetic. It is also very important that you ensure both your blood sugar levels and your blood pressure are as well controlled as possible, as this also gives you the best possible chance of maintaining a good level of vision. Leakage from the capillaries affecting the central retina causes a gradual blurring of vision due to waterlogging of the retina, and this is called macular edema. If the leakage from the abnormal blood vessels is away from the very central part of the macula, then treatment can be given by applying spots of laser to try and seal the leaky blood vessels. The laser treatment, however, is destructive as it burns the retina, and it cannot be applied if leakage is at the very centre of the macula. These days, there are anti-VEGF drugs which have been used extensively for a different condition, wet macular degeneration, that are now being used more often for macular edema involving the very central part of the retina in diabetes. The injections need to be given relatively frequently in the first year of treatment, and often once a month for the first few months, but it appears that the frequency of injections is reduced in most patients with diabetes after a year or two. Leakage from abnormal blood vessels in diabetes is also associated with inflammation, and it has been shown that slow-release steroid capsules injected into the main eye cavity can reduce macular edema in diabetic patients due to damping down the inflammation. These steroid injections tend to be reserved for diabetic patients that have already had cataract surgery and do not have glaucoma, as cataract formation is a side effect of steroid injections. If there is considerable blockage of the capillaries, the retina tries to produce new blood vessels, but unfortunately they are not helpful blood vessels and do not help the circulation, but grow into the jelly that's called vitreous that occupies the main eye cavity. The jelly then pulls on the blood vessels, causing them to rupture with sudden hemorrhage into the main eye cavity, resulting in a large number of floaters and blurring of vision. The patient may not be aware of having had any problems prior to this developing. This hemorrhage into the main eye cavity is called a vitreous hemorrhage, and the abnormal blood vessels growing in association with poor circulation is called proliferative diabetic retinopathy. If you have this condition with the abnormal blood vessels developing, then treatment involves extensive laser to the peripheral retina, which is where the circulation is at its worst, and this is called pan-retinal photocoagulation, or PRP. It obviously has to be given when there is still a view to the retina, and if significant hemorrhage has occurred into the main eye cavity, it is too late to perform laser, and the hemorrhage will either have to settle down of its own accord as the eye can absorb the hemorrhage, or it may have to be removed surgically with an operation called a vitrectomy. In patients with very severe proliferative diabetic retinopathy, the new blood vessels can be accompanied by scar tissue, and this can contract and distort and detach the underlying retina. And in this situation, more extensive vitrectomy surgery is required to remove the scar tissue.